Good afternoon, ladies and gentlemen. Welcome on Linet Symposium dedicated to patient positioning. Patient positioning is well documented at least 150 years from time of crime war when Florence Nightingale started to position the injured soldiers every 2 hours to prevent pressure sores on the bed. Today we will look on different aspects of patient positioning, which is focused on effect of patient positioning on mechanical ventilation. My name is Martin Richel, and I will do my best to guide you and go with you through this entire conference. We prepared for you 3 phenomenal speakers that will give you, I really believe, phenomenal lecture. First speaker I would like to introduce now is Professor Marcelo Amato. He is present online, based in Brazil. Professor Marcelo Amato is author of several very important concepts of mechanical ventilation, and his first lecture is called When Gravity Matters More Than PEEP and Tidal Volume. I see Professor Marcelo Amato online. Good morning, Marcelo. So please take a lead and you can start your presentation.
Thank you. Good morning. Good morning, everybody. In fact, it's good morning in Brazil. Let's start. Okay. Enhancing lung protection when gravity matters more than PEEP and tidal volume. So we are on the surface of Earth, and gravity is the most important force. It creates this, let's say, force in nature called superimposed pressure inside the lung. So every organ inside our body is attracted to the center of Earth. And because the lung is kind of soft structure, is a semi-liquid structure, we have this superimposed pressure where the height of the column of the lung on top of each part of the lung multiplied by the density of the lung creates the superimposed pressure. So big animals like this or small animals like this have a big problem. This is the 3D reconstruction of the lung. This is the perspective if you are inside the belly of this tiny rabbit. This is the right diaphragmatic surface, the left one. And then this animal is using PEEP of 10. If we suddenly cut the PEEP and put this animal at zip, you see these big atelectasis, so the lung is completely non-aerated, and you have to imagine that this lung was cut by a knife, and this is the level where the superimposed pressure is above 3 centimeters of water. So this is happening to our patients all the time. You have to imagine that the lung is a sponge. The density of this sponge is 0.2 grams per cubic centimeter. If you have ARDS or if you have COVID-19 disease, the density is going to increase by 3 or 4 times, almost the density of water. And especially when you have big patients like this, you have a big gradient of density. You can see that we measure the heterogeneity of the lung, and 55% of the heterogeneity of the lung is caused by the gravity axis. You can see the cranial-caudal axis or the left to right axis doesn't cause any heterogeneity. In fact, this is measured by CT. This is apex, the caudal part of the lung, sternum, spine. We can see that we have almost isogravity lines from head to the most caudal part of the lung. So when you have a patient laying on the bed, you have to imagine that you have a gradient of densities caused by gravity, like this, organizing the lung like layers with increased superimposed pressure. When you are prone, you have the same problem. And when you have lateral positioning, you have this big gradient. Okay, this gradient can be bad or can be good, depending on how you use it at the bedside. Just to give you an idea, this is a patient of us. We are going to decrease the level of CPAP. Blue is very aerated lung, and red is almost collapsed lung. If I decrease the level of CPAP, I can see that I start to see lots of collapsed tissue on the right lung. And there is the gradient is still there. I have a difference in transpulmonary pressure of approximately 15 centimeters of water, much higher here and much lower here. Okay, just 1 second. I'm going to try to have a better pointer. So if we have a patient with COVID, this patient is going to stay on the bed for 3 weeks. And we know from many reports in the literature that the compliance goes down along the weeks. And why compliance goes down along the weeks in patients with COVID? Essentially because of the cubitus atelectasis. This has been well documented by some researchers. Also some lung fibrosis, but we had the hypothesis that we could avoid this drop in compliance by avoiding the cubitus atelectasis. In this paper, published 2 years ago in anesthesiology, we have demonstrated that patients under anesthesia, just laying down on the bed, had a big amount of collapse after surgery, just because they stayed laying down during anesthesia, despite the normal one. So a PEEP level of 4 is not enough to avoid this big atelectasis after extubation. If we apply enough PEEP in these patients, in this case dictated by electrical impedance tomography, we can avoid this big atelectasis. How much PEEP we need? This is a summary of more than 50 patients. The optimum level of PEEP to avoid atelectasis depends on the body mass index. You can see that this level can be very high. In some patients, I need 17 of PEEP, despite the normal lung, just because anatomy and obesity. And but there is a big spreading depending on the individual anatomy. If you avoid atelectasis, you apply this optimum PEEP in those patients, you have a decrease in driving pressure of at least 6 centimeters of water during anesthesia. And as we know, driving pressure is the mediator of ventilator-induced lung injury. And by applying this lower driving pressure during anesthesia or during post-operative situation, we can decrease the length of stay of post-operative cardiac patients, and we can decrease the stay in the ICU. Also, you observe a much lower need of oxygen supplementation during the postoperative phase. This is the first and the 5th postoperative day. We have much less patients needing oxygen if you avoid this decubitus atelectasis by applying enough PEEP in those patients. So in patients with COVID, and this paper is going to be published soon, we have shown that the same problem is happening. And if you apply enough PEEP, you can increase the respiratory system compliance, and you can sustain a big improvement in compliance as compared with the control group, in which we are applying PEEP FiO2 tables like the ARDSNet table. You can decrease the driving pressure by 4 centimeters of water, and you can enhance the percentage of patients breathing room air. And we have a difference of at least 5 to 6 days less of mechanical ventilation by applying the proper strategy to avoid atelectasis. So how atelectasis work? Which are the driving forces of atelectasis? This is a representation of a recruiting maneuver and decremental PEEP steps. Let's follow these by electrical impedance tomography. This is the image of overdistension on the left and of collapse on the right at a PEEP level of 24. If we decrease progressively PEEP levels, we decrease overdistension until the point we start to see some collapsed tissue. You can observe that collapse is dorsal and hyperdistension is ventral, because the animal was under this position. Now, if we turn the animal under prone positioning like this, the atelectasis in supine was in dorsal regions, but if we turn the animal to prone, and you can see that PEEP levels are decreasing and collapse is increasing according to this curve. So now we are going to turn the animal to prone positioning, and you see now the atelectasis moving to the ventral portion. In fact, EIT is flipped because the belt is fixed on the thorax of the patient. You should present these images like this. And you can clearly see that atelectasis is on the dependent position and in ventral part close to the bed. And again, obeying this curve where collapse increases as you decrease PEEP levels. Something very surprising. When we measure the amount of collapse according to different PEEP levels, doing this decremental PEEP steps maneuver, we had exactly the same amount of collapse in prone or supine position. Also, the same amount of overdistension. This was a little bit surprising because everyone believes that prone promotes less atelectasis. This is absolutely not true. And as you can see here, this is the percentage of collapsed tissue. This is the amount of pulmonary shunt. And this is what happened when the animal is under supine positioning. Now, if we turn the animal to prone, we can see that despite the fact that we are still having 50% of collapse, I have much more shunt in supine as compared to prone, 60 against 30%. Why this is happening? Because perfusion is very different during prone and supine. And when we measure perfusion with EIT, we could detect that perfusion was always dorsal, whatever the lung positioning, the positioning of the animal, always dorsal. So perfusion is not obeying gravity. For instance, in this animal under supine positioning, I see lots of atelectasis on the dorsal parts of the lung, and I see lots of perfusion in the dorsal part of the lung. If I superpose one image to the other, I see lots of perfusion in atelectatic areas and no perfusion in aerated lung. So high perfusion in atelectatic areas. If I turn the animal to prone, again, I see a big amount of atelectasis, as much as in supine positioning, but still my perfusion is very dorsal. And when I superpose both images, I don't see perfusion in collapsed areas. So I have minimal shunt. And this is the explanation why oxygenation improves in prone. And not exactly because I have less atelectasis. I just have a movement of the atelectasis. And if I'm smart enough, I can use this advantage in my favor. So the same amount of collapse according to PEEP levels, but much less shunt when turning to prone. So this was very impressive. It was a little bit against the old dogma of John West, and this caused a big surprise to Professor Hedenstierna. So unfortunately, Professor Hedenstierna passed away a few weeks ago, but he was the most brilliant physiologist alive, and he's studying this problem of atelectasis during anesthesia. And he gave big lessons about the problem of atelectasis for all of us. Very important messages. So it's important to understand that prone position does not necessarily decrease overdistension. Like in this patient, prone positioning was causing more overdistension than supine positioning. But the important message here is that when I flip the patient on the bed, I can completely change the gravity axis. And if you're smart enough, you can use this in your favor. This patient was under supine position. This is the collapsed tissue curve according to different PEEP levels. So when this patient was below 15, collapse was increasing a lot, but this is the overdistension curve. So overdistension was decreasing when PEEP was lower than 15. So this is the patient under supine positioning, and we see that the optimum PEEP in this patient was around 40. And when we turned the patient to prone positioning, I needed higher PEEP to keep this patient with minimum levels of collapse. So the changing in position is not going to change too much the level of collapse, but you can use this in your favor as a recruiting maneuver. And you have to imagine that the positioning of the patient in the bed is going to affect everything you do under mechanical ventilation. For instance, if this patient is supine, this is the collapse and hyperdistension curve. And you can see that the optimum PEEP for this patient is 11. But if this patient is under Trendelenburg, now I have more gravity forces applied on the lung because the weight of the belly is being applied on the surface of the diaphragm, and I need more PEEP to avoid lung collapse. The same happens if you do lateral positioning on the bed. For instance, this patient under supine positioning had a lot of hyperdistension on the right lung because he had asymmetrical lung disease. Now, if we make lateral tilt on this patient, I can decrease overdistension in the right lung. And obviously, I'm going to increase a little bit the overdistension in the left lung. This is represented in this curve. So this patient under supine position had much more atelectasis as compared to the lateral positioning. Let's observe what happened in our patients at the bedside. So this is a typical map of collapse when we do PEEP titration in EIT. This is the collapse curve. So we see that hyperdistension is decreasing across decremental PEEP steps, and I'm starting to see some collapse at a PEEP level of 40, and then progressively more collapse at low PEEP levels. So how can we use gravity in our favor at the bedside? You have to imagine a maneuver more or less like this. If you have a patient in supine positioning, you have lots of atelectasis in the dorsal part of the lung. Then you turn the patient prone. Immediately after, you are going to have lots of dorsal atelectasis, but progressively along the time, and this is very quick. In 5 minutes, you have a situation where atelectasis decreased, started to form in the ventral part of the lung, and then if you now apply enough PEEP to keep the lung open, you can turn the patient to supine and avoid any atelectasis. So you have to use gravity and hysteresis in your favor, and then by just changing patient positioning, you can remove atelectasis without the need of a formal recruiting maneuvers. And we have used this more and more at the bedside. And as an example, this patient was under supine position with very little ventilation in the dorsal part. When they turned the patient to prone and then flipped back to supine, we could have a lot of ventilation in the dorsal part of the lung. Let's think about now lateral positioning. So we did some experiments in pigs and in patients, turning the patient to lateral position. How we can use it in our favor? Okay, I'm going to represent here the pleural pressures. Okay, this is pleural pressure. I put a sensor in this part of the lung and in this part of the lung, and I'm using EIT here to represent this patient, or in fact, an animal. What happens when I flip the animal like this? So just tilting the animal. Look what is going to happen with the pleural pressure. Let's take a sensor placed on this positioning. 1 second. So the pleural pressure is going to decrease because now gravity is creating more negative pressures in this part of the lung and more positive pressures in this part of the lung. So pleural pressure is going to decrease. Transpulmonary pressure is going to increase, and right lung volume in blue is going to increase, and left lung volume in red is going to decrease. So we put these animals under CT, using this box to flip the animal under CT. You can see here the animal under the gantry. We used also simultaneously EIT. And what we measured is that when I measure air content, for instance, in this part of the lung, the right lung, when I flipped the animal, I can see the reversal of atelectasis. And then when the animal was supine again, atelectasis is gone. So I promoted a recruitment maneuver, and the hysteresis acting in our favor kept the animal open when the animal was supine again. So this is why when using positioning at the bedside, you can recruit an animal or you can recruit a patient and use later on hysteresis in your favor. And we documented this by using EIT and CT. We can see that when we do these maneuvers at the bedside, we have a big improvement in recruitment. You can see lots of atelectasis here, but after this tilting of the patient, just one turn, 20 minutes left, 20 minutes right, we had the reversal of atelectasis. We had an increase in the length of the lung and a big improvement in lung function in oxygenation and in the dimensions of the lung. So one very interesting finding during this study is that when you divide the lung in quadrants, so lower right quadrant, upper right quadrant, and so forth, we can see that this quadrant is going to have increased the transpulmonary pressure and increased aeration. The same for this quadrant. But surprisingly, this quadrant is going to have a decreased aeration. And more surprisingly, this quadrant is going to have an increase in aeration, contrarily to our predictions. So flipping the patient on the bed has also a very interesting physiological effect, that the weight of the abdomen is removed from the dependent diaphragm, and you have some recruitment also in the dependent lung area. And this enhances our physiological effect. So lateral tilting has much more physiological effects that we were anticipating. I don't have time here to discuss all the benefits of this maneuver, but let me just tell you that using EIT, we quantified how much force we create on the lung when we do this kind of maneuver. And what we observed is that every tilt in the lung, when you do it with 20 or 30 degrees, is equivalent to a recruitment maneuver with more than 8 or 10 centimeters of water. So it's a big physiological effect that you can use in your favor. And for instance, in this patient that had left lung atelectasis, when we promoted some tilting of this patient, we had a massive recruitment of the left lung. Let me just show you this. You can see that this patient is starting to aerate. Just because we tilted the bed, we can see here that we tilted the bed 20 degrees, and we started to see some aeration of the left lung, and suddenly, just an aeration, but suddenly we started to see some ventilation. And you are going to see that the amount of tidal volume variation in this lung is going to increase progressively, and this lung is going to be completely recruited by just tilting the patient to the lateral position. So what we are doing at the bedside now is that in many patients, instead of applying a recruiting maneuver, we just keep enough PEEP to keep the lung open and just use some lateral positioning of the patient, which can be done automatically by new devices to recruit the patient and starting to reverse atelectasis. So we have seen lots of examples like this. We have measured the increase in transpulmonary pressure in these regions. We have understood that we create a big gradient of transpulmonary pressures in the lung that now is in the non-dependent part of the gravity. But we have also demonstrated that you have an increased transpulmonary pressure on this lower left quadrant. And this is very helpful at the bedside. Just to give an example, this is the PO2. So the patient was under supine positioning. Then we just increased the PEEP level to 12, okay? Because this was the PEEP level that we thought that it was enough to avoid atelectasis. Then we did left lung decubitus, supine again. Right lung decubitus, supine again. And then we decreased back the PEEP level to 10. Look what happened with the PO2. A big increase along the time and a big increase in compliance. So the same patient now, we didn't perform the tilting, but the patient was back to a PEEP of 10 and decreased atelectasis back after 6 hours and go back to the same PO2 level. Now we just increased the PEEP level to 12 and waited for 6 hours. No effect. So in the same patient, and we did this along the time for many animals and patients, we can prove that the tilting increase PO2 and increase atelectasis well beyond the effect of PEEP. We have proven that we can decrease atelectasis on CT much more than just waiting. We can decrease the collapse much more than just increasing PEEP or waiting a few hours. And we have done in a series of patients. And the effects are very consistent. We always increase aeration in the lung that is flipped to the upper position. And you can decrease a little bit the aeration in this ventral part of the lung. But then doing the reversal of the flipping, you have a beneficial effect along the time. I don't have time to show all the benefits, but I would like just to share that the tilting of the patient at the bedside can have unbelievable effects on the lung physiology, and we have to start using this much more in our favor. Thank you very much.
Thank you very much for your really brilliant lecture. I always enjoy your lecture. Thank you very much. And I would like to ask our participants if they have any question for Professor Amato. You have no questions? I have one. So, Marcelo, you spoke about mainly the most serious patients and your strategy for patient positioning. What is your strategy for less severe or mild patients? Do you have any strategy or ideas how to lead the positioning for those patients?
Thank you for this question, Martin. Yes, we are doing some studies on post-operative patients and patients recovering from abdominal surgery or cardiac surgery. And obviously with COVID patients. I think the physiological effects are there, and it's happening all the time. Especially for cardiac patients, this kind of maneuver has been very helpful because we don't need to apply high PEEP levels or recruiting maneuvers, and these patients, they typically have some hemodynamic instability. And we are starting to measure the cardiac output continuously, and we can see that, for instance, if you are this lateral tilting is much better tolerated in terms of the hemodynamic system than, for instance, elevating the head of the patient, elevating the bed. So the lateral tilting is very stable hemodynamically and can be used as a very important recruiting maneuver, much more than elevating the head of the bed.
So thank you again. We have one more question. This is last question. We are so please go ahead.
My question was all this knowledge. I think it's great to hear this, but how do you apply this knowledge when you do your ward round in the morning and you have a row of patients waiting? How do you do that?
Martin, I just missed the one word. So when what I can do when I have what waiting patient?
Okay, I will try to repeat the question. So, if you have many patients who are waiting for your treatment, how you are able to apply this positioning strategy for many patients in your ward. Was the meaning of the question,
Okay.
right?
Okay. I understand. Thank you very much. I think no question that we have to evolve. For doing this kind of maneuver, we are using online monitoring now more and more. I think in the future, we should have, for instance, like we have pulse oximeter for every patient, we should have an EIT, online image for all the patients, like an ECG, constant ECG. In fact, in our ICU now with COVID patients, we have more or less one EIT for each patient, for each bed. And then the tilting of the patients is a little bit cumbersome. And in some of these studies, we did it manually or with some tables on the bed. But now we have automation of this, and we have new beds, so in which you can program this all the time. You can program it continuously. But in fact, I think the program should not be continuous. We have observed that just one complete cycle of this turning in positioning typically is enough to recruit the patient. So you just program one cycle, like lateral, supine, other lateral, and supine again, and you're done. And typically, you don't need more than 20 minutes in each position because gravity is acting very fast. Like when we turn the patient in prone, we have also measured this. The reversal of atelectasis is quick. Then the effects in oxygenation is slow, but the reversal of atelectasis is very quick.
Thank you very much for your lecture, Marcelo. We really enjoyed that. I would like to introduce next speaker, who is Michael Otahal. Michael Otahal is a chief of intensive care unit from Prague, from University Hospital Prague, and he would like to share also with us his experience with the patient positioning.
Hello, everybody. I'm very glad to be here and have an opportunity to share with you my perspective of optimization and individualization of mechanical ventilation. First, I have to say I'm not professor yet. So, okay. We have cooperated with Linet since 2013, and right now we have some research project together with the Timpo. So this is my conflict of interest. How can we optimize mechanical ventilation? What is protective? Protective is prevention of ventilator-induced lung injury. How can we do this? By minimization of mechanical power and driving pressure. We have to optimize PEEP. How can we do this? By PEEP titration using by some imaging, CT, ultrasound. We can use some global parameters as a compliance, oxygenation, PV curve. We can optimize the PEEP by volumetric CO2, but right now it's trendy, and we can gently titrate the transpulmonary pressure by using esophageal pressure. But what it's now clear, we can use electrical impedance tomography to set the optimal PEEP of our patient. And when we have the tissue like this, so only one way how to optimize driving pressure is to reopen this collapsed part, and we can do this only by homogenization of the ventilation. We can use some recruitment maneuver, but as you listened before, we can use some positioning. In 2010, SAT published this meta-analysis, and have not proved for all group of the patient that prone positioning was not significant. There was no difference between the proning and the non-proning patient. Only when cut the patient or subgroup with PO2 FeO2 index below 100, it looks beneficial for mortality with this significance. Then came the professor trial, and Garin showed us when we start early and in soft criteria, because prone positioning used before this in patient with 10 PEEP and 60% of fraction. So when we use this soft criteria as a starting point, and we use the prone position at least at 16 hours, we can improve the mortality in our patient. So from this time, from 2013, Proseva trial established prone positioning as evidence base. But it's not only about proning. Maybe we can use in asymmetric lung injury as in the patient, when you see more, skip. If you have the patient like this, with more asymmetric injury, we can use only lateral. There's some problem because it skipped not exactly as I. And we put the patient in this position, or maybe better is put in semi-prone position, 135 degree, and put the patient in this position. This collapsed part have to be up. Effect of semi-prone position you can see, or lateral position you can see in this picture. This was a patient with lobar bronchopneumonia. We start the positioning, and in 24 hours you can see this improvement, and after 40 hours this huge improvement in tissue on the right side, just because the patient was lying on the left side. So open the lung and keep it open. This is all basic concept by Lachman, published in 1992. When we have collapsed tissue, as you see here, we need some time, and I'm not sure if the time 20 minutes is enough, as said Professor Amato. We need some time and some opening pressure to recruit and reopen the dorsal part of the lung. Maybe we can use some recruiting maneuver, and maybe it have been processed in some disposition, in prone position. Because we know that every overpressure in the thorax is bad for our hemodynamic, then we try to minimize the PEEP by some process, some PEEP titration, and we try to identify, we try to identify closing pressure and then set the optimal PEEP up to closing pressure. When you see this video, this part of the lung tissue is opening and closing alveoli in every breathing cycle, inspiration, expiration, and this produced villi by the atelectatic trauma. So we will some here in this position. Different story. When we use some recruiting maneuver, the pressure is more higher. You can see this part of the tissue. It takes some time to reopen all alveoli. Maybe it's not easy, but takes some time. But be sure if we reopen this part and reaerate this and homogeneize the ventilation, be sure the ventral part will overdistend it, and we protect the volume trauma. So, maybe this is better in this position. Electrical impedance tomography, only one technique or one technology right now in the world which can show us the ventilation screen, what's happened inside the lung. Breath by breath, we measured global parameters, we can measure global parameters, we can measure distribution, but what is more important is the inside distribution on the into lung. So we can use some tool in the electric impedance machine, PEEP titration tool. Step by step, we reduce the lung, the pressure, the PEEP, and as we saw before, we can obtain these global parameters, compliance, overdistension, and the collapse. We can use these global parameters to identify that there is some point which is best in compliance, just beneath the crossing, hyperdistension and the collapse, and we can identify the optimal PEEP, in this case in 12. But what is more important, we have regional information from this PEEP titration. When you're lowering the PEEP, as was said before, we can identify the collapsed part and the overdistended part. Everything what is white color here is hyperdistension. Everything is in blue color here is collapsed part of tissue. So we can identify what's happened inside the lung. And when we made some or performed some PEEP titration, it's our patient, step by step we reduce the PEEP. And what is optimal PEEP? Optimal PEEP is a PEEP with minimal overdistension and a minimal collapse. Here in this position 14. So remember 14, yeah? The same patient, PEEP titration, step by step reduce the PEEP. You can see disappearing of white hyperdistension, and you look, there is absolutely different view because we homogenizate the ventilation of this patient, and the optimal PEEP is 12, maybe better than, and how we can do it only by prone positioning. So we homogenize the ventilation by the proning. It's not about only about ventilation, it's about ventilation perfusion match. You can see here the different left and right in ventilation and perfusion. And when the patient in the prone position, we can optimize the VQ match, as you see in here, just by moving, reopening the left part of the lung. So this was effect of prone position. Another patient, another PEEP titration, step by step reducing the PEEP, and again you saw absolutely different view because there is no level of PEEP without white and blue color. Optimal PEEP here will be approximately 12. Less collapse, less overdistension. Maybe better will be 14 for this patient. So remember 14, and again, next PEEP titration. It's very slow, sorry, not working properly. So again, you can see absolutely different story. You remember before we have in the same level hyperdistension and the collapse, huge collapse and huge overdistension, hyperdistension, and what we see here on this patient, the optimal level in the 12, there is more homogenized the ventilation, and is made by ALT. What is ALT? ALT, we will show you, is automatic lateral therapy. It's a Linet technique for tilting patient. We can tell the predefine percentage of tilt, predefine the time, and it goes then automatically. So we use it in a lot of operation. But back to the patient. If we have the patient like this one you saw before, we have overdistension and the collapse in the same PEEP level. We decide to put the patient in this position with collapse part up. And what's happened? We start automatic lateral therapy, right 30 to back, we use 60 to 60 minutes. I'm not sure that Professor Amato have a right and talk about 20 minutes only. We use it for a long time. And the difference between this patient after 15 hours of ALT is huge difference. Disappeared collapse, disappeared overdistension, and in the same level of the PEEP, 12, we reduce overdistension, we reduce the collapse, and improve the compliance, only by the tilting of the bed. Nothing changed. Again, it's not only about ventilation screen. We can use perfusion mapping. And before, in supine position, there is this mismatch. And after automatic lateral therapy, we optimize the VQ match by the reduction or, by this, we're opening this part of the lung. So we improve the VQ match. It's not only about lateral tilting. When we have the patient like this with amputation of perfusion, you can see, and amputation, full amputation of ventilation here. This because right lobar pneumonia in this patient. We put the patient just only lateral position, 90 degree. It's very slowly, sorry. And we improve the VQ match again, just by reopening this part of alveoli. So it's not only about these cases. We have published with Professor Amato and with Mikulas this paper. And when we put the patient in the automatic lateral positioning, we significantly reduce in the left lung collapse with this significantly, and we reduce again overdistension in this part. So, next two slides. What is protective? Protective is individualization of our patient. Not every patient has the same therapy, but we should use some safety borders. But we have to optimize our PEEP, and what is more important, we have to only reduce the driving pressure, always in the mechanical pressure, mechanical power, by homogenization. And how can we homogenize the ventilation, the tissue inside the lung? By rewrite the patient by some recruiting maneuver, but what is more clear right now is we can do it by the positioning, prone or electrical targeted automatic lateral therapy. So my message for you, there is no optimized setting of mechanical ventilation without optimal or right position of the patient. Thank you for your attention. Thanks.
Thank you very much, Michael. Thank you for a very nice presentation. We are running out of time.
Okay.
Anyway, in this room is still a free slot, so we can continue for a last presentation. If you don't have a time, I would like to invite you to Linet booth and discuss and see the part of the presentation that will be done now on the Linet booth. If you can stay, please stay and continue with us to the end of this session. Thank you, Michael. If you have any question for Michael, please keep your question and ask after this meeting. Thank you. And now I would like to invite Mikuláš Mlček, Nick Mlček. Nick is Chief of Laboratory of Experimental Physiology in Charles University, Prague. And he would like to share with us some practical demonstration of the effect of lateral tilt using healthy volunteer tilting bed produced by Linet and electrical impedance tomography.
Thank you very much, Martin. Thanks for those who are staying. We're very sorry for the delay, but I think opportunity to listen to Marcelo Amato is always, at least for me, highest priority. So we fully understand that you might have other commitments. I'll shorten the talk, shorten the demo. The purpose of this part would be for you to see in real what we were talking about. And let's run into it. I'll be skipping very many slides. Anyways, Marcelo mentioned most of that. If I make this, if I ask you advance, is that also good? So we'll talk about the concept which took us some time to work on. If you can carry on. Okay, so it's difficult for me to advance slides. Let's jump into the demo immediately. So now we will try to show you this healthy volunteer. He's healthy, but principles, gravity acts on him exactly as Marcelo mentioned. He is not intubated, he is obviously non-invasive, and our original thought was to devise this for intubated severe ARDS. Now we see much easier understanding and benefit for unilateral or asymmetrical disease, but I'll try to show you that it may work even for symmetrical. And now let's see how fast and how much these interventions can be. We will switch into slightly different screens so that we can see, let me explain. If you see on your screens, the ventilation map is each breath in and out. If I ask you to breathe deeply in and hold your breath for a second, immediately we see that. Thank you, you can resume. Above that there is a share left and right, so which lung breath is more, which one left. This one is completely physiological result. The graphs which are running are again in real time. Auto-scaling, which is a bit against us, but let me switch to longer time frame. It's 4 minutes. And this is volume of air over time. So vertical is volume, and there you see the time running. Each breath is one spike. The big one is the big breath I was in. Blue one is both lungs, global, let's say volume. It is compliance in reality, but it represents volume. The middle one, the middle white one, is right lung, and the bottom one is left lung. White, left, right, and left. Now, this is him spontaneously breathing with 3 PEEP and 5 support. What we'll do, we'll turn left, which means left down. If we say left lateral, it's left down. What do you expect to happen? Part of it is very intuitive, part of it is contra-intuitive. So we will see in real time. Everybody is slightly different, but again, let me repeat. This is the right lung, the middle is the right lung, and the bottom is the left lung. You see how rapidly this responds in healthy. It may not be identical in sick patients, but it may be identical. It can be extremely variable. And we have increase in volume. So end expiratory volume is now increased. How much is it increasing? It's increasing by about tidal volume. So at the moment, 400 is total tidal volume, and it's increasing still. It's not stabilized yet. The other one has decreased. Now imagine if this is your patient. Which one you like? Increasing or decreasing volume? Again, depends what's your goal, but in the patients we're talking about who's got collapsed lung, we usually don't like the reduction in volume unless they are hyperinflated. Can we prevent that? So we are gaining volume. We're kind of, as Marcelo Amato says, opening the lung. We're losing a bit. Total gain is positive, but still we may not be happy with the bottom lung being compressed. So the easy trick that everybody would probably do is try to offset this by some form of PEEP. So Michael is intensivist, he would know what to do. And let's see how that works in real time again. So to offset this tilt in the bottom lung, now it seems that he had good guess what to do. Again, everybody's different, so it's not that one size would fit all, but it seems we're offset that. And how much was that, Michael?
5 centimeters of PEEP.
So this tilt is additional 5 centimeters of water for the lung, or needs 5 centimeters of water to compensate for it. This is one change. The other one, which is less intuitive, is which lung breathes more. If you look here on the screen, which of these lungs has more ventilation? Again, this is CT-like, so right 40, left 60. So it seems intuitive that left lung breathes more. It's down, it's compressed, it breathes more. It's for us, when we see it first time, it took months to figure out. This happens in 90% of people, healthy people. It may be different in patients because it will depend on PEEP. But yes, commonly the upper lung, by opening, gets stretched and it gets more inflated, maybe nearer to hyperinflated. The bottom lung, though it is smaller, is near the steep side of the compliance curve, so it may be easier to open. So commonly the top lung, as we see in Marcelo's slides, may be kind of overdistended or near overdistension. That's why it very commonly may breathe less. Now, we see there is some dynamic change, which is mostly because it's spontaneously breathing. In ventilated patients, we would probably have them well sedated, and these lines will be very straight, much easier to read. Now we'll probably reduce the PEEP, and shortly we'll return back to supine. What we wanted to demonstrate in this real-time demo is the magnitude of the effect. So we see the magnitude of the effect was at least VT. Again, it will be different in different patients. Rapidity, it's seconds to minutes, but in patients it may be tens of minutes. And the necessity to combine position and PEEP, because by positioning we could lose. If the lung, which was at the bottom now, left lung, was so-so, and we do this one, maybe we don't want to get there. So it is difficult to predict, and very nice to have real-time monitoring. Also other positions, and Marcelo Amato mentioned also elevating head or moving up legs will have rapid effect. But now let's see what happened after we returned. So we reduced the PEEP, we've changed the position. PEEP change was 5, position was 30 degrees. Initially we thought it was no change, like 30 degrees. Our guess in the beginning was not much will happen. We thought it will be necessary to go at least 90. So that's we were very wrong. So now we see that the change in right one is twice tidal volume, which is, again, now we're having leaks, so we cannot read properly, but it is a few hundreds of mLs. That's how rapidly it acts. Okay, I think we're done with this live demo. Maybe we'll elevate this one. Okay, and we have immediate effect. So optimization of ventilation, regional optimization, is possible with the knowledge of what's happening regionally, with body positioning, which will inevitably affect it, and with the right setting of PEEP. So now, though we have elevated head or backrest, actually we're losing a bit of volume, which again may be reasonable, maybe not. The principles in, if you look into it for a while, they're not too difficult. It usually is a combination of gravity, pressure, including intra-abdominal pressure. So my guess now is there is some increased pressure by this maneuver, and pathology of the patient, which we need to know even from imaging or other methods. Okay, this is for demo. I'll run through a few slides if possible. Let's try. Okay, it's much better. It's keep going both ways. Anyways, we were running out of time, so let me summarize. I'd like to summarize that this method is allowing us to act individually for every patient. Of course, you have to have it connected, but some units, what they do typically in France, they have one unit, and every patient has just the electrodes attached, and they can run around them. So we can individualize, we can see local differences which are impossible to see from global parameters from ventilator. They are difficult to see from X-ray because you need to call someone in and out. Of course you can, but it takes time. CT takes more time. Ultrasound, of course, nice, but again, it will not give you full coverage like this one. They are very dynamic. The nice part of that one is you've got history here. So if you look into trends, you can see what happened overnight. And so you can look back what happened, which maneuver helped or which not. And it allows you to immediately see the response or effect of your ventilation control. And it is functional image. So like we say, which lung breathes more, this would be similar if we had X-ray. If you see white lung and black lung, which one breathes more? And I'd like to conclude with this case, which was a very interesting case Jabba has witnessed. White lung, unilateral, and quite good black one. Which one ventilates more? You see the X-ray, say this is good one. Black one is good one, it'll breathe, this will not breathe. Actually, it may be very different, and depending on your PEEP and position, it may be any combination. If your PEEP is very high, this lung will be overinflated and will not ventilate, even in supine. If you have this patient and accidentally do nursing and start lateral for decubitus control for something, and put the white lung, the edematous lung probably, on the right side, what do you expect happens? Again, difficult to say without seeing, because it will depend on the severity, on PEEP and on position, and also on time, also on intra-abdominal pressure, on obesity. But may easily happen, and we've seen the case where by turning on the right side, the lung will collapse, and this patient will fast or very gradually deteriorate. And we'll learn this after 3 hours, because that's when we take blood gases. But while the change usually occurs a bit faster. Or if we have right PEEP, it may not deteriorate that fast. So these combinations of positions and PEEPs are quite easy to monitor now. 90% cases easy to interpret. We only have to have the data. And as Marcelo Amato said, we can use it for our benefit, which is with less aggressive maneuver than opening maneuver, we can try to open the lung. One more benefit, it is usually just one part of the lung at a time. So for example, from a cardiovascular perspective, we are not challenging the right ventricle that much, because still, even if we are over-distending one lung, the other one is not being over-distended that much. So there is still chance that it will be hemodynamically tolerated better, as actually Marcelo said. Regarding the timing, and we did not fully agree with Marcelo. Again, we've seen enormous variability in how fast this change occurs. So mostly in healthy, it is seconds, less than a minute, as we see today. In some patients, it is 10 minutes and occasionally tens of minutes. And we've seen cases where if we put it on automated, like Michael prefers automated, overnight, every hour move, it happens in 3 a.m. Starts opening the lung. That's what we have seen in several patients. So it's very difficult to predict, and personalization here is, as always, and we hear it every day, quite useful. So that's what we wanted to show you. I'm sorry that we were unable to load the slides properly. I hope we have given you the best of our knowledge. We have very little knowledge of perfusion, and we hope to understand perfusion during next year, and hopefully update you with red images, which will be blood, and red and blue, which will be VQ match. Thank you very much for your attention.
Thank you, Nick, for your fabulous live demonstration. We are over the time, so thank you for your participation. The video record from this presentation will be available on website of ISICEM and also available from Linet. I would like to thank to the technological partners of this short company symposium, especially Linet, producer of the multi-care bed, which allows a safe and easy patient positioning, company Timpel Medical, producer of electrical impedance tomography, and company Hamilton Medical, provider of this brilliant ventilator. Thank you very much for your participation.